Thank you for attending this session on the National Standards for DSMES Standard 5. My name is Michelle Stansel, and I look forward to reviewing this standard with you. Standard 5 is Person-Centered DSMES. Person-Centered DSMES is a recurring process over the lifespan for a person with diabetes. Each person's DSMES plan will be unique and based on the person's concerns, needs, and priorities collaboratively determined as part of a DSMES assessment. The DSMES team will monitor and communicate the outcomes of the DSMES services to the diabetes care team and/or referring physician or other qualified healthcare professional. So let's start with when to refer to a DSMES program. There are 4 critical times to consider a referral to DSMES: at diagnosis, annually, or when not meeting treatment targets or personal goals, or the person with diabetes has questions about technology or treatment options. When complicating factors develop, such as neuropathies, advancement of kidney disease, or when transitions in life or care occur. For example, pediatrics transitioning to adulthood, adults in pregnancy and parenthood, adults transitioning to retirement, to just name a few. So when we look at Standard 5, every DSMES intervention should be a person-centered process. It begins with an assessment, and we're going to look at each of these in more detail. A DSMES plan of care that includes timely education that's supportive of the individual needs. There's a variety of sessions and session methods. There are action-oriented behavioral change plans, clinical outcome measure or measures, and communication. So we're going to break in with the assessment. An assessment of the participant is performed in the following areas that we're going to discuss to develop the person-centered DSMES plan. Participants receive a comprehensive assessment that includes baseline diabetes self-management knowledge, skills, and readiness for change. So this process, the assessment process, is information provided by the person with diabetes. And it may include those that have been identified as support persons or caregivers. There's a lot of information to collect at the assessment. So prior to the assessment, we strongly encourage you to utilize the health record or electronic health record. A lot of this information is collected at various locations on the person with diabetes journey with diabetes. So it may be in there. And a lot of people may get frustrated if they're asked a question that they just answered a couple of weeks ago at their doctor's office. Send questionnaires. You can send them by mail, text, consumer portals. Consider web-based tools. And reminder, ongoing assessments will be incremental over time. It's just not a one-time service that we deliver. It happens again over time. When we're completing the assessment, it's a critical time to identify gaps and help close the gaps. You might identify referral opportunities, barriers to getting tools needed to self-manage. And then from this assessment, a DSMES plan of care is developed. So the assessment includes current concerns, needs, and priorities. Remember, this is a partnership and collaborative process with the person with diabetes. They're providing a lot of information to assist us to assist them. It's personal, it's private. We gather health status information, what type of diabetes, health history. We're including social determinants of health and health inequities, risk factors. We're learning their learning level. What is their diabetes knowledge base? Are they ready for DSMES, literacy, ability to self-manage? We're identifying their lifestyle practices, and this is going to change over time. How are their self-management skills, their resources, cultural influences? We're assessing their alcohol and drug use, lived experiences, and including sexual orientation. And then we're doing psychosocial assessments. What kind of support does the person have? Diabetes distress, promoters or barriers to DSMES. So there is a great tool to help with this process. The ADA Quality Coordinator Guide has an organized list of what is included in the comprehensive assessment. Diabetes pathophysiology and treatment options, healthy eating, being active, taking medications. As you can see, this list is great. And we're going to take a look at some examples. And because this list is so comprehensive, you may think, oh goodness, how am I going to get all of this? So our first examples begin with some questionnaires. So at our organization, we see all persons with diabetes, so pediatrics, adults, and pregnancy. So we have an assessment for each population that we serve. So that is a suggestion. Develop a questionnaire. These are some examples of questions from our assessments. The ADA also has some examples. And what we do when we schedule an appointment, that assessment appointment, we mail these assessment forms or we send them by an electronic patient portal. We encourage the person that we've scheduled the appointment with to bring it back if we are mailing it to them. At the appointment, we encourage people to arrive at least 15 minutes early for the registration process. At that time, if this questionnaire has not been completed, then we issue it. Then there's about 15 minutes that they can be working on it to assist with that assessment appointment on gathering this information. We have other questionnaires. Remember, we're gathering social determinants of health. So we have a social determinants of health screen tool as well that we, again, can mail, send by electronic patient portal, or issue at the time of an appointment. And, assess your population. Here at our institution, we service a lot of individuals that speak Spanish. So all of our questionnaires are available in both English and Spanish. Plus, we also have other languages. Another example of a questionnaire is our progress questionnaire. This is something that we issue, again, by mail. We also complete this by telephone, or we send it by electronic portal at the 3 to 6 month post-program when we assess how they are doing on their self-management journey. We may identify that the person can benefit from a follow-up appointment, or we can congratulate them on that they're continuing to do well on self-management. We remind them of our support options, and that any time that they need a return based on those 4 critical times that we are here to provide additional DSMES services. So as far as an electronic medical record example, as you can see here, each session, and we'll talk about this further, is documented with the date and time of service, the type of service provided, the length of the service, and then we assess their knowledge based on the disease process, those elements that we need to assess at the assessment. At follow-up appointments, we establish where they have come. Do they need instruction, need review, do they comprehend? And this helps with follow-up appointments. I want to thank Prisma Health for these examples. So we've gathered that information from a comprehensive assessment. Now we are going to develop a plan of care. We're going to develop action-oriented behavioral change plans. We are going to measure clinical outcomes, and we're going to monitor and communicate services. Let's look at each one individually. Implementing the person-centered DSMES sessions is based on that DSMES plan of care that was developed at the assessment. At the conclusion of the assessment, we have a plan of care. Additional DSMES has been determined to be needed. We work with our person with diabetes to see what their preferred delivery and timing is. Today, we're offering both in-person and virtual options. Timing could be they want only Friday afternoon. Maybe they need evening appointments or Saturday appointments. So those are things that are included in the plan of care, whether they're going to do individual or maybe it's going to be a combination of individual and group sessions. And then a reminder, documentation. Each session is documented. It includes the date, the time, and the topic. We are tracking outcomes, both action-oriented behavior change plans, what's important to that person, what they want to work on. We'll look at some goals in just a moment, but then we're also tracking clinical outcomes and the impact that DSMES has on the person with diabetes. There are a variety, many options of clinical outcomes that can be measured. You may measure A1C values, A1C net change, quality of life, DSMES satisfaction, DKA prevention, emergency room visits or readmission reduction, missed school days, and there are many pregnancy delivery outcomes from gestational age of delivery, pregnancy or infant outcomes, any complications, NICU length of stay. So align clinical outcomes with your organization. What is important to your organization? And then these are a few examples of clinical outcomes that can be measured. So let's take a look at some examples. Here's an example of a session. This session is a basic exercise education session. The reason for the visit, who is present today, the person may have brought a support person with them. The length of the visit. At each session, whether it's an assessment or a follow-up session, we do complete a hypoglycemia assessment. We may identify that somebody is tolerating hypoglycemia, and we let them know that this is dangerous, and we can communicate with their provider any treatment recommendations that we've identified to reduce hypoglycemia. We reinforce hypoglycemia interventions. So it's a great assessment that we do at each encounter. As far as this basic exercise education, the method of instruction, if there were any barriers to learning, the topics that were addressed, education materials that were issued, PowerPoint, the American Diabetes Association Starter Walking Plan, ADA Overcoming Barriers, Getting Moving, Breaking, and Breaking the Sitting Streak. We use the curriculum Life with Diabetes. It has wonderful handouts for each of the lesson plans. The handouts for exercise are 6.1 to 6.5 in the latest edition of Life with Diabetes. And then we also issue ADA chair exercises. And we identify the level of understanding following this visit. Again, we want to thank Prisma Health for this example. And then we have an education plan. What's going to happen after this session? Will there be follow-up sessions? Does the participant, are they going to call back and let us know based on their schedule? And then what is the diabetes care and education specialist going to do? Did they identify that the participant maybe would like a referral to an exercise program? Or have there been other things identified at this session that the diabetes care and education specialist is going to follow up on? And then communication is key. You're communicating not only to the diabetes care and education specialist team, but to the provider. We're going to see some examples in a minute. Is the provider linked in your electronic medical record? Are they external and you're going to fax this information to them? You can often do that through your electronic medical record system. Was the educator's contact information provided? Usually it always is. What is the participant's preferred method of communication? Do they want to communicate by the patient portal? Do they prefer text, a telephone call? And then, of course, we let them know if you have any questions between our next visit, please let us know and we'll be happy to address them. So here's an example. The patient is going to return in 4 weeks to the medical clinic. The session has been scheduled. The patient is going to call if they have any questions before that appointment. Was the contact information of the educator provided? Yes, it was. This referring provider is linked in the electronic medical record. A goal for this participant that we track, this participant selected a nutrition management goal. Their specific goal was to avoid all sugary beverages, and they're meeting their goal at 50%. We do aggregate these goals. That is seen here in the right-hand corner. That will be discussed in Standard 6. So we do hope you attend that session on the National Standards, DSMES, Standard 6 presentation. As far as clinical outcomes, we track post-A1C, A1C post-DSMES program, an example here, but we also track patient experience or satisfaction and many other clinical outcomes. We track several clinical outcomes, but with patient experience or satisfaction, how likely would the person be to recommend the DSMES service is a questionnaire that our organization sends out. That is in addition to our patient progress follow-up. So in summary, Standard 5 is person-centered DSMES. It includes a comprehensive assessment. From that assessment, a DSMES plan of care is developed and education sessions are scheduled. At each of those sessions, we are monitoring the behavior change plan that has been selected by the person with diabetes. We are measuring clinical outcomes pre and post DSMES service that measures the impact of DSMES. And then we are communicating with the referring provider and the care team. There are additional ADA tools to help with this. This is a great pictograph on the initial comprehensive DSMES cycle. It includes everything beginning with the person with diabetes, the referral, the comprehensive assessment, the plan of care, the education interventions, the outcomes, the behavioral goals that were set, the behavioral goal follow-up and outcomes, additional measurements, and then communication with the referring provider at each intervention. We actually use this as an audit tool. So each of our DSMES, diabetes care and education specialists, audit at least one DSMES record. They also edit an M&T record annually, using this DSMES cycle. To go along with this pictograph is this review form. A, that was just illustrated here, is the referral. B includes all of the elements of the assessment. And this helps to identify, are there any modifications that you need to make to meet this comprehensive assessment requirement? C, the plan of care. D, the summary of the interventions, each documented. The learning outcomes is E, behavioral goals that are set, behavioral goal follow-up G, clinical or quality of life outcomes, and then documentation. So let's test your knowledge. There are 4 critical times to consider DSMES. This is something that we all need to know. It is at diagnosis. Is it at diagnosis, annual visit, or not meeting treatment goals, personal goals, change in condition, transitions of care? Is it all of the above? Yes, it is. All of the above. True or false? An assessment is completed only once. The answer is false. Years ago, it may have only been completed once. Today, after your initial assessment, ongoing assessments will be incremental over time based on the individual need. Remember, a person just doesn't come to DSMES once. They can come to DSMES through their lifespan when they have a change in condition, when there's transitions in care, if they have questions at their annual visit or they're not meeting personal goals or treatment goals. And our final question. A colleague shares that their DSMES program offers the same education services for everyone referred to their department. Does this meet Standard 5, Person-Centered DSMES? I'll give you just a minute to think about that. And the answer is no. Many participants' plan of care may include the same or similar education services. However, it is unlikely that all individuals referred to that DSMES program would receive the same service. This does not sound like an individualized, person-centered DSMES. So what could you recommend? Well, you can consider referring this colleague to the national standards for DSMES. Maybe they haven't reviewed the documents and realize that it changes about every 5 years. You can refer them to the quality coordinator guide. It's a wonderful resource. Or you can recommend that they attend an ERP symposium. So that concludes our session on Standard 5. Please check out the next video. There's going to be another example of Standard 5 from a quality coordinator from another DSMES service. Thank you for attending.